Now let's talk about mycoplasma. Mycoplasma, number one, it is of the order Mycoplasmates or Mycoplasmatales, and it's divided into four genera. This order, you have got Eperithrozoon, Hemabatonella, and then you have got Mycoplasma, and then Ureaplasma. And the most clinically significant that we'll be talking about is of the genera Mycoplasma. So Mycoplasma has got 124 species, and then Ureaplasma, which has got 7 species. And the most important species is Mycoplasma pneumoniae. Okay, that's the most important species that we'll be able to talk about. Now, when you look, there are of course other commonly isolated pathogens like Mycoplasma genitalium, Mycoplasma hominis, and also for the Ureaplasma, you have got Ureaplasma urealyticum. So these are other important commonly isolated pathogens. So again, the key species for mycoplasma that we'll talk about, you have got mycoplasma pneumoniae. This one causes what we call a typical pneumonia, especially in the adolescents. Mycoplasma genitalium causes what is known as non-gonococcal urethritis, because gonococcus can cause also, we talked about Neisseria gonococcus, okay, gonorrhea. So that one causes inflammation of the urethra, but non-gonococcal cause of this inflammation of the urethra, you have got this mycoplasma genitalium. Okay, it also causes pelvic inflammatory disease. And then you have got mycoplasma hominis. This one causes postpartum fever, so fever after giving birth, and also pelvic infection. And then you have got ureaplasma urealyticum, which causes genital tract infection, and also neonatal meningitis in a neonate. Okay. So what are the features of mycoplasma? They don't have a cell, and this is important for them because this gives them that flexibility and resistance to some antibiotics. You have got a lot of antibiotics which are actually targeting the cell. We call them cell wall synthesis inhibitors. For example, penicillins, cephalosporins, you have got the carbapenems, all these guys, monobactams, these classes of antibiotics that I've listed, which are very, very important, they are actually going to target the cell. But then these guys don't have a cell. So meaning that you can't give penicillins for these guys. You can't give the ceftriaxones, which are cephalosporins. You can't give the meropenems, which are carbapenems, all right? The monobactams. And then the gram stain, they don't stain with gram stain. Why? There's no peptidoglycan to be able to hold that gram stain. And also when you look at the shape and size, these guys are pleomorphic. They have got varying shapes, and they're extremely small, and many can actually pass through the 0.45 micrometer filter, which is used to remove bacteria from solution. So this is a filter used to remove bacteria from solution, so meaning that using this filter, it will not be able to work for mycoplasma because it's very small. And when you look at the membrane, they also contain sterols. So peculiar for them, okay? And it's uncommon for a lot of bacteria. And these sterols basically stabilize the cell membrane. And for the growth requirements, these guys require an enriched media with sterols because that's what they contain, like the SP4 broth. Mycoplasma and ureaplasma organisms are the smallest free living bacteria. In contrast, other cell wall deficient bacteria, which is called the L forms, they do not have sterols in their cell membrane and can form cell walls under the appropriate growth conditions. However, the organisms divide by binary fission, okay, which is of course typical for all bacteria. They grow on artificial cell-free media and contain both RNA and DNA. Now, mycoplasma are facultatively anaerobic. Okay, meaning that they work where there's no oxygen, but in case oxygen is there, they can as well work to produce energy. Except Mycoplasma pneumoniae, this one is a strict aerobe, so you can guess where it will want to cause infection. That is why this guy causes pneumonia, because it wants to be in the lungs. That's where there is oxygen. Okay, it's a strict aerobe. Okay, so most of the mycoplasmas require oxygenous sterols, and actually all of them require, because they have got steroids. So the mycoplasmas grow slowly with a generation time of 1 to 16 hours, and they most form small colonies that are difficult to detect without extended incubation. So if you want to grow these guys, you need to take a long period. So you see what, so culture for them is going to be tricky, because it will require that long period of time. The pathogenesis, they have got what we call the P1 adhesin. This P1 adhesin enables the mycoplasma to be able to attach to the epithelium of the respiratory system. Okay, they actually specifically target the cilia on tracheal epithelial cell walls. And then what they'll do is that once they attach there, they'll cause ciliary stasis and damage. Okay. So they'll be able to interact specifically with the ciliated glycoprotein receptors at the base of the cilia on the epithelial cell walls, and also on the surface of erythrocytes, the red blood cells. And that is going to result in seriostasis. Basically, the cilia can't move. Okay, when this occurs, the cilia is not able to move, and then the cilia is going to get destroyed, and that would disrupt this mucociliary clearance of the upper airways, and that will permit the bacteria to spread to the lower respiratory tract, because it can't be cleared. So it will end up going to the lower respiratory tract, and then they will be able to enter the cells. The species will invade the host cells, and then they'll be able to survive in the cell. So this process is responsible for the persistent cough present in patients with symptomatic disease. Okay, so Mycoplasma pneumoniae functions as a super antigen that stimulates inflammatory cells to migrate to the site of infection and then release cytokines. So initially, tumor necrosis factor 1 alpha and interleukin 1 and interleukin 6, these guys are going to be released, and they'll cause fever and malaise. These are the B symptoms, which are or constitutional symptoms, which are normally present when there's an infection like pneumonia. Okay, a number of mycoplasma species are able to rapidly change expression of surface lipoproteins, which is believed to be important for invading the host immune response and establishing persistent or chronic infection. Now, when you look at the Mycoplasma pneumoniae, it is a strict human pathogen, and it causes respiratory disease like tracheobronchitis, basically the inflammation of the trachea and the bronchioles, and also pneumonia. Okay, so this disease occurs worldwide throughout the year with no consistent increase in seasonal activity. Like, it doesn't increase in the cold or maybe in the winter, summer. It is throughout the year. Epidemic disease occurs every 4 to 8 years. In other words, normally it is endemic, like it's always there in this environment. But after 4 to 8 years, it can become an epidemic. Okay, like the cases increase slightly higher than normal. That's the meaning after 4 to 8 years. So this disease is the most common in school age children and young adults, those that are between 5 to 15 years. Although all ages can be affected, but it is normally in this age group. So Mycoplasma pneumoniae disease is not a reportable disease, meaning that if the cases rise, it's not really a reportable disease, something that is much of worry. Okay, reliable diagnostic tests are not widely available, so the true incidence is not really known of the true people that are really having this disease. So Mycoplasma pneumoniae is not part of the normal flora of humans. However, prolonged carriage can occur following symptomatic disease. So if someone has got a disease, they can carry this guy for long, but it's not part of normal flora. Infants, especially the females, are colonized with Mycoplasma hominis and Mycoplasma genitalium and Ureaplasma species, with Ureaplasma organisms being isolated most often. Carriage of these mycoplasmas usually does not persist. Okay, a small proportion of prepubertal children remain colonized, but it normally doesn't persist. Like, the bacteria doesn't normally persist someone still is a carrier, only a small proportion. The incidence of genital mycoplasmas rises after puberty, corresponding to sexual activity. Okay, because this guy is related to sexual activity. So after puberty, there's much of sexual activity, and that's why the incidence gets to rise more. And now, approximately 15% of those that are sexually active, men and women, have got mycoplasma hominis, and 45 to 75% are colonized with ureaplasm. So you can say that ureaplasma is more common than mycoplasma hominis in the sexually active. The incidence of carriage in adults who are sexually active is not greater than that of prepubertal children. So whether you are a prepubertal or you are an adult, the incidence of carriage is still the same. Okay. So some symptoms that are going to be seen if someone has got infection with mycoplasma, you have got low grade fever, and this is basically pneumonia, low grade fever, malaise, headache, a dry cough, non-productive. Okay, it sometimes can be non. So a dry cough is actually non-productive because you are not coughing out anything, and the cough normally develops 2 to 3 weeks after exposure. Okay, acute pharyngitis may also get to be present, the inflammation of the pharynx, and symptoms gradually worsen over the next few days and can persist for 2 weeks or longer. The bronchial passage primarily becomes infiltrated with the white blood cells, the plasma cells. Pneumonia, which is primary atypical pneumonia, also known as walking pneumonia, can develop with a patchy bronchopneumonia seen on chest X-ray. Okay, that is typically more impressive than the physical findings. So the physical findings might not be that bad, but when you do a chest X-ray, you'll be able to see this patchy bronchopneumonia. Okay, myalgia, the pain of the muscles, and gastrointestinal tract symptoms are very uncommon. Secondary complications include neurological abnormalities, like there will be disturbance of the central nervous system, pericarditis, inflammation of the pericardium, hemolytic anemia, arthritis, mucocutaneous lesions. These are secondary complications that can happen later on. Okay, so the clinical disease, the most common clinical presentation of mycoplasma pneumonia is a tracheobronchitis. So what is going to happen is that transmission is via respiratory droplets. Okay, asymptomatic colonization is common, especially in close contact setting, like in children who are at school. One has got a disease, they're coughing, and then they can get to spread to others, and then they become asymptomatic carriers. So early symptom onset is 2 to 3 weeks after exposure. So there's going to be low grade fever, malaise, headache. This is because of the cytokines. There will be a dry, non-productive cough because of ciliary disruption, and then there'll be pharyngitis where there will be mild sore throat. Okay, but when someone has a child, especially a child, has got a sore throat, a child as a sore throat, it is something of worry. You need to make sure that you do something very quickly, because a sore throat in a child later on, normally, because the sore throat can be caused by the group B, actually the group A beta hemolytic streptococcus, like Streptococcus pyogenes. And later on, what happens is that they can develop what we call rheumatic fever. Rheumatic fever, later on, they can develop rheumatic heart disease, and that is bad because it can lead to heart problems. But even mycoplasm can cause this pharyngitis where someone is going to have only a mild sore throat. But sore throat, again, in children should be investigated, especially between 5 and 15 years. Okay. Another thing that can happen is tracheobronchitis, which is the most common presentation. This is upper airway inflammation. So the symptoms gradually intensify for several days, may persist for greater than 2 weeks. And histologically, bronchial mucosa is going to be infiltrated by the lymphocytes and the plasma cells. This is the hallmark of non-bacterial inflammation. Okay, bronchial mucosa is infiltrated by the lymphocytes, which are the white blood cells, and the plasma cells. So the lower respiratory involvement can also happen, may evolve into primary atypical pneumonia, also known as walking pneumonia. This is the involvement of the lower respiratory tract. Radiological or clinical dissociation. So there's going, when you look at the chest X-ray, there will be punchy bronchial pneumonia on chest X-ray, and then mild auscultatory finding. There will be crackles. Actually, these are the features of pneumonia. When you're doing a respiratory exam, you do inspection, percussion, palpation, auscultation. So for auscultation, you hear these crackles. Okay. which can be few, but for the imaging, like the chest X-ray will be so dramatic, it's so clear. Myalgia can also be present. GI symptoms can also be present by diarrhea. Okay. So, what are the secondary complications again of mycoplasma infection? Neurological, they can be encephalitis, transverse myelitis, Guillain-Barré syndrome, which is the ascending paralysis. So someone is just going to be paralyzed. And then cardiovascular, it can be pericarditis. Hematological, there will be autoimmune hemolytic anemia. Musculoskeletal, there will be arthritis. Dermatological, there will be erythema, mouth foaming, Stephen Jones syndrome. Okay, this is for the skin. Now, the genitourinary tract is going to be colonized by other mycoplasma species and ureaplasm, and it is difficult to determine the role of this organism in disease in individual patients. Okay, really, what is the role of ureaplasm? What is the role of other species? So, it is generally accepted that Mycoplasma genitalia causes non-gonococcal urethritis and pelvic inflammatory disease. Ureaplasm urealyticum will also cause non-gonococcal uh, urethritis, also pyelonephritis. This is pus in the kidney. Okay, and then also spontaneous abortion or premature birth. So this is bad. When you find this guy in a pregnant woman, you want to do something very much because it can cause spontaneous abortion. Mycoplasma hominis also can result in pyelonephritis, postpartum fever, fever after giving birth, and systemic infection in the immunocompromised. For diagnosis, you can do the molecular diagnosis, which is very sensitive. All right, it's excellent. Microscopy is not really useful because these guys don't have a cell wall, so they don't stain with a gram stain. Culture is the definitive, okay, diagnosis. If positive, can confirm live organisms, but it is so slow, like 2 to 6 weeks, so it's rarely used. You can also do complement fixation to measure the antibody response versus the glycolipids, though it has got poor sensitivity. Enzyme immunoassay can also be done, supposed to be ELISA to detect the IgM and the IgG. So some will be able to detect what we call the P1 adhesin for better specificity, okay, the ELISA. And then you can also have the code agglutinin. So histological, this is an histological test. So it's IgM mediated. Okay, there's going to be agglutination, clamping together of blood. So treatment, erythromycin tetracycline is important. A specific tetracycline that uses doxycycline. Fluoroquinolones are also effective. Okay, preventing of mycoplasma disease is problematic because the infections normally spread by close contact, so prevention is really difficult. Isolation is also impractical, however, because patients are typically infectious for a prolonged period. You can't isolate someone for a very long period. Okay, even when they are receiving antibiotic treatment, they will still be uh, able to spread the infection. So inactivated vaccine and attenuated live vaccines have also proved disappointing for mycoplasma. Protective immunity is conferred by infection, and it has also been low. So if you get the infection, it doesn't mean that next time because your body has developed immunity you not get sick. You still get sick. Okay. Infection with Mycoplasma hominis, genitalium, and ureaplasma are transmitted by sexual contact. Therefore, when you want to help someone, at least ask them to stay away from sex, or at least use protected sex, be involved in protected sex. All right, some questions. What is the primary adhesin used by Mycoplasma pneumonia to attach to respiratory epithelial cells? Remember, that is the P1 adhesin. Why is Mycoplasma pneumonia resistant to beta lactam antibiotics? It lacks a cell wall, isn't it? Okay, the beta lactam antibiotics, these guys, how they work is by basically stopping the synthesis of the cell wall. What is the most common clinical presentation of Mycoplasma pneumonia? It is tracheobronchitis. Of course, you have also pneumonia, acute pharyngitis, myalgia, gastrointestinal symptoms. Which diagnostic test is considered the most sensitive for detecting Mycoplasma pneumonia? So the most sensitive is molecular PCR, polymerase chain reaction. What type of pneumonia is commonly associated with Mycoplasma pneumonia? It is primary atypical pneumonia, also known as walking pneumonia. All right, which immune response is primarily responsible for the pathology seen in Mycoplasma pneumonia infection. That is cytotoxicity by the bacteria. It's not really the bacteria that causes harm. It is actually my body responding to the bacteria that causes problems. What extrapulmonary complication is commonly associated with Mycoplasma pneumonia, acute kidney injury, autoimmune hemolytic anemia, myocardial infarction, pancreatitis. So it is autoimmune hemolytic anemia. Of course, there are many others, all right, like pericarditis. Okay. What is the hallmark radiological finding in Mycoplasma pneumonia? What is the pneumonia? What is the hallmark radiological finding? So we had mentioned it's a patchy bronchopneumonia. The physical findings, like when you look at someone, you examining them, they might not appear well, but when you do imaging, this patchy bronchopneumonia will be prominent. Which antibiotic class is the most effective against Mycoplasma pneumonia? So remember, the beta lactams can't work because this target a cell wall. Okay, aminoglycosides, these guys will target protein, sulfonamides target folic acid, macrolides are better. And macrolides we had mentioned here, you can see we have got the erythromycin. Okay. What is the role of cold agglutinin testing in diagnosing Mycoplasma pneumonia? Okay, this guy is neither sensitive nor specific. The cold agglutinin we had mentioned, it here. Okay, basically where you are trying to see if blood will be able to clamp. Which Mycoplasma species is associated with non-gonococcal urethritis? Is Mycoplasm genitalium. Of course, we had mentioned that it's not the only one. Mycoplasma urethriticum can also cause the non-gonococcal urethritis, but the common one is the Mycoplasm genitalium. Which Mycoplasma species is associated with postpartum fever and systemic infection? That is Mycoplasma hominis. What is the primary mechanism of Mycoplasma pneumonia pathogenesis? So these guys will basically attach pneumonia, will attach to the sedated epithelial cells and cause the cilia to stop moving, seriostasis. Which immune-mediated phenomena can occur during Mycoplasma pneumonia infection? Okay, so they can be called agglutinin-mediated hemolysis. So when there's Mycoplasma pneumonia infection, there will be this hemolysis, the breaking down of the red blood cells. So which immune mediate this one is immune mediated. Okay, it's the immune system that is coming to get to destroy the red blood cells. Direct bacterial invasion of red blood cells, really not. Endotoxin induced shock, not really. Endotoxin mediated tissue destruction, not really. Okay. And the last question: which Mycoplasma species is associated with pyelonephritis and pregnancy complications? Ureaplasma, urealyticum, this guy is involved with pregnancy complications. What are examples that we said? We said that it can actually lead to when someone is giving birth, can be abortions, spontaneous abortions, or premature birth. So that is it for this class. Thank you so much for being present.